Thank you very much for sorry. Thank you very much for GIS board for this for their effort to make the GIS conference prosperous year after year. So my case for today is a 50-year-old gentleman who has diabetes, hypertension, obesity, started with sleep apnea, and he had non-STEMI and had coronary angio, and it showed a three vessels disease. He was referred to surgery, and then he came asking for possibility for PCI. By assessing the left anterior descending artery, the LAD stenosis, it was moderate lesions by the FFR. So he turned back to be a two vessels disease, not three vessels, the left circ and the left circ with the OM. So as you can see here that the LAD doesn't have significant lesion, but the significant lesions actually are the ostium of the OM, mid-OM, and mid-circ. So straightforward BCI to left circ. The RCA did not show that it is the RCA is CTO and totally occluded and has collaterals from the LAD and from the circ. So my plan was to go for the circ and to do the PCI for the circ and the OM, and to postpone for another stage to do the RCA. So straightforward intervention for the left circ, two floppy wires, and the strategy was to go for DK crash for this case, which was successfully done. I will not go in these steps one by one. But I would like to pay your attention to the wire in the circ where it directed. And after that, I changed the direction of the wire. I was concentrating on the stents, and the stents were fine. The procedure was done very well. But if you can see this, sorry. The stent there in the branch of the left circ, maybe OM2, there is some staining there. So it was my concern, and to look for that perforation in the wire exit perf. So it's clear now that I have there something in the, and the stain is increasing gradually. And at this point, I was...
Yeah, I was doing the same.
Shukran, Dr. Abdullah. Thank you. So the stain is there, and I kept observing this, this staining. It looks increasing, but there is no pericardial effusion. Patient is stable. Everything is good. So I waited for half an hour almost, and nothing happened. So I pulled the wire and sent the patient to the CCU, but I was afraid that this is not ellipse class 1 or 2. Maybe it will be 3, I don't know. But for half an hour waiting inside the cath lab, nothing happened. So I transferred to the CCU. As expected, the patient after 1 hour actually, he did not develop any symptoms, but his blood pressure went down, start to go down, and the heart rate start to increase. So once I said, okay, something will happen, more disastrous, more important. So I took the patient back, I did for him an echo, and I start to see a pericardial effusion. So once I saw the pericardial effusion, immediately took him to the cath lab. I insert the catheter to aspirate for the pericardicentesis. And as you can see here that the heart rate is, the heart is beating fast. So, and I want to check for that wire exit perf. Where is it? It's not there. There is no staining there, but I'm quite sure that it was the one. So I chase and search, and I found this, as you can see here, there is some staining at the same site where I was afraid of. So I went there, and I have the options now to put a coil and to occlude it. The problem that I have CTO and the RCA, I want the collaterals, every single collateral going to the RCA for the coming PCI to the RCA, so I don't want to put a coil in the OM and to close the OM, even though, or it was of more choice actually, no more choices actually, that I don't have coil at that moment. So we need to ask for it and to wait for 1 hour to deliver it to this cath lab it was not available at that moment. So not having it, so I was trying to find out where's really the small branch there and to occlude it. So I went with the selective injection with the microcatheter, avoiding increasing the perf, and the stain is there. There is no clear perf there. So I went with the usual way of embolizing it, either with fat embolus, clotted blood, even sutures. Every time I have the stain is there, it doesn't go. So even at the end of the day, I start to use, after all of these, and to close the small branches there, it was difficult to close it. So I elect to go with part of the balloon or half of the balloon, top of the balloon, and push it there and try to close that very small branch. After that, the stain is still there, so I don't know which branch actually to go. I went with another one, another part of the balloon, try to fix it, try to stop it. The stain is still there. So now, either to have the coil and close the OM or to have the foam gel. I prefer to go with the foam gel, and actually to deliver the foam gel and to close the perf, you need to go with the maneuver of not to have slippage of the foam gel proximally. So the microcatheter was went there and trapped by a long balloon, inflated. And here, very important point actually, when you deliver the foam gel, that to mix it with some contrast, so you will have the myocardial blush, so you will not go too much and cause more perf. And this is by the end of the day. I have occluded, everything is stopped, patient is stable, and the vessel has been occluded. You can see that from the proximate in the distal part. And after that, I did the CT core angio after 3 weeks, which showed full recanalization of the vessel. So now I have the OM back, I have the collaterals back to the RCA, and everything went smoothly, even better than the coil option. So my conclusion, actually, from this case, what I learned, that even a small branch can cause problems, fatal problems, and the small stain should not be ignored and keep under eye observation. And some of the many techniques actually used to close the exit actually were toward failure. And maybe the gel foam was the last solution when you don't know exactly where the perf is. And all cath labs should have the safety measures before starting any PCI, even if it is simple. Thank you.
Excellent, thank you.